Fibromyalgia, trigger points, and chronic myofascial pain. A. New understanding. Fibromyalgia, a hypersensitized central nervous system. Fibromyalgia doesn't cause aching muscles. It doesn't cause numbness and tingling. Yes, patients with FM can have these symptoms and many others, but these symptoms' origins have been terribly misunderstood. So have the patients. We are beginning to understand the process that creates the central sensitization state we know as fibromyalgia. FM is the term given to a family of illnesses that have in common central nervous system, CNS, sensitization, and chronic diffuse systemic pain. FM is systemic, not local. The nervous system is divided into central and peripheral sections, although the dividing line may be fuzzy at times. The CNS is composed of the brain and the spinal cord. The rest of the nervous system is peripheral. These systems blend and meld in places, but the differences are very important to patients with these conditions and to their care providers because their treatments are different. An initiating event or series of events and responses occurs in FM, creating a state of CNS hypersensitization. This affects wind-up or temporal summation of second pain, TSSB. TSSB is the best indication of FM pain intensity, Staud et al., 2004, and is an important concept for both FM patients and their care providers to understand. If an intense, severe pain or other stressor hits the CNS, it is considered first pain. The brain and spinal cord figuratively cringe and do their best to recover from the assault. If the assault continues or the pain or other unpleasant stimuli becomes chronic, the next assault is called second pain. The CNS starts to adapt, changing in an attempt to protect itself. It begins figuratively, again, to tense the shoulders of the brain, clenching the fists of the spinal cord, and causing little nerves to quiver, waiting for the next blow to fall. As you can see in the figure, if the stimulation recurs or continues, the base pain level climbs higher and takes longer to return to its original level. With continuing or recurring stimuli, the pain level may not come all the way down again. The base may continue to climb as long as assaults continue, and the CNS is further sensitized. In FM patients, CNS sensitization requires less noxious stimuli to spike. The pain level and after effects are greater and more prolonged. Staud et al., 2003. TSSB and central pain in FM results primarily from peripheral stimuli. You must gain control of the peripheral stimuli to control the central pain. Fibromyalgia pain amplification. Temporal summation of second pain wind-up, reproduced with the permission of Roland Staud. FM is characterized by hyperalgesia, amplified pain, and allodynia. Some days, everything can hurt. Even the pounding of rain on the window can seem as if sharp crystals or walls of pressure are whipping at your cells. That's part of the world of FM. Peripheral stimuli, such as TRPS, may initiate noxious sensations such as pain, nausea, or dizziness, and FM amplifies them too, and the pain or other sensations can outlast the stimulus. Research verifies that the central sensitization of FM can be initiated and or maintained by peripheral pain. Staud, 2006. The referred pain of TRPS is itself a manifestation of central sensitization. Gerwin, 2010. In FM, the filters that protect healthy people from CNS overstimulation are not working adequately. The FM patient may not be able to pinpoint sources of pain because his or her brain is totally preoccupied with attempting to handle a deluge of pain and other stimuli. In uncontrolled FM, anything that can shock the CNS, including pain, loud noises, and any other startling stimuli, must be moderated or avoided. Any CNS assault can lead to FM flare. During flare, old symptoms worsen and new ones may appear as new TRPS activate. Everything is hypersensitive, since few articles on FM patients account for the coexistence of TRPS. It's not known if the flare response is actually multiple TRP activation. We do know that the CNS may take a long while to calm down and may never return to its former level of sensitivity. Staud et al., 2004. Relatives may not understand the cost of holiday season demands on an FM patient and employees with FM may pay heavily for mandated overtime. The lack of external support also adds stress to the patient's lives. Attempts to explain may be met with disbelief or dismissed entirely. Patients pay heavily for the lack of general medical and legal understanding. Cognitive dysfunctions may be the most disruptive aspect of FM, although some of those disruptions may be due to the chronic pain itself. Dick et al. 2008. The brain is otherwise employed processing pain stimuli and literally can't deal with anything else. It may not be able to recognize a jar of mustard placed on a different shelf or remember a sequence of numbers or a sequence of anything. Brain dysfunction specific to FM has been documented. Glass 2008. You may feel as if your head is stuffed with cotton and nothing else. This can cause difficulties with the simplest of tasks and may cause patients to appear and feel stupid, even if they belong to Mensa. Dr. Glass and her team have shown that for patients with FM working tasks, executive memory, and semantic memory deficits equal about 20 years of extra aging. Yet you look fine, so people expect you to act accordingly. Some FM patients have difficulty following a book or television show because they can't remember the characters. Russell and Larson, 2009. The existence of these symptoms has been confirmed by the results of objective tests of metamemory, working memory, semantic memory, everyday attention, task switching, and selective attention. More complex tasks cause greater difficulty, as will distraction. Short-term memory can be especially affected by distraction. Cognitive impairments can vary with fatigue and mood. Pain has the greatest effect on perceived language deficits, not concentration or attention, and lack of restorative sleep most affected perceived memory deficits. Williams et al. 2011. FM cognitive deficits can be profound and yet be undetected by conventional cognitive assessment techniques. Levitt and Katz. 2009. Research has revealed a pattern of impairment in working memory and attention/executive control as well as memory impairment. Glass 2010. Even when global processing is unimpaired, there is frequently a significant impairment in selective deficits, such as specific naming speed skills. There are new simple tests that may prove useful. The cognitive deficits of FM are neurological, not psychological. The present data suggest that associated psychological distress and maladaptive emotional responses that are commonly attributed to the general FMS population may be largely a distinguishing feature of one subset of patients. Salguero et al. 2011. Spatial memory may be more impaired in FM patients than verbal memory. Kim et al. 2011. This may be caused by biochemical brain trauma from the sidetracking of tryptophan to the kynurenine pathway. On this metabolic path, instead of needed serotonin, the result is quinolinic acid. This metabolic pathway is utilized in at least a subgroup of FM patients. Schwartz et al. 2003. Quinolinic acid is a neurotoxin that causes spatial memory impairment in rats. They can no longer find their way through their maze. Is quinolinic acid causing the same chemical brain trauma in FM patients? This experiment may be ongoing without our knowledge, perhaps as FM patients attempt to traverse the maze of medical insurance and managed care. We don't yet know, and certainly haven't, given consent. Neither did the rats. FM patients can have significant cognitive deficits that tend to increase in times of stress, or if hormones are unbalanced. This is important for care providers to remember, especially as this may make communication difficult in emergency situations or during stressful office visits or medical procedures. These cognitive deficits could be mistaken for dementia in the elderly. They can worsen dramatically if the FM patient is overexposed, exposed to stimuli, such as in a large crowd, with lighting, varying colors, and patterns, odors, and noise. This sensory overload can overwhelm the brain and the patient quickly. Sensory overload can initiate a panic or shock state. It can also initiate a stress response: fight, flight, startle, or freeze. It's important to remember that this response is neurological, not psychological, and requires decreased stimuli and increased recovery time. FM is not exclusionary. One may have FM and many other conditions: impaired balance, falls, dizziness, irritable bowel, sexual dysfunctions, sleep impairment, numbness, dyspnea, burning, etc. Often ascribed to FM may be from coexisting conditions such as insulin resistance, TRPS, thyroid resistance, or vestibular dysfunction. One of the first steps in managing FM is to discover what condition is causing or contributing to the most significant symptoms. It is important to know that when the CNS is hypersensitized, pain is not the only symptom that is. Enhanced Geiser et al. 2008. Fibromyalgia has many invisible symptoms. Along with the pain and cognitive deficits comes sleep deprivation and fatigue. Patients may feel anxious or depressed because no one can tell them why they hurt or what they can do about it. They may feel helpless and hopeless. Quality of life can spiral downhill as financial and other resources are depleted. Friends don't know what to do or say, and patients and their caregivers may become isolated. So far, we've seen massive denial from the general public and the medical establishment, except, of course, from those pharmaceutical corporations who are now making a tidy sum from FM patients. They have a vested interest in placing all symptoms under the fibromyalgia umbrella. FM can be divided into subgroups depending on the initiators of the central sensitization state, including but not limited to infections, severe or sustained, physical trauma or emotional stress, exposure to toxins, severe or persistent pain, such as can be caused by TRPS, persistent lack of restorative sleep and/or existing metabolic imbalances. Many cases of FM have multiple initiating factors. Some cases of FM are initiated by TRPS. We don't know if TRP formation could be an intermediate stage between any initiator, such as an infection or trauma, and the central sensitization of FM. It takes time for central sensitization to develop after a sudden initiating event. Are TRPS forming during that delay, preparing to set patients up for chronic pain? We don't yet know. Sometimes the FM initiator is slow, such as sustained grief, stress, or overwork, often involving tight muscles, and TRPS. Whatever the cause of FM, TRPS help to maintain the central sensitization once FM develops, and are avenues for controlling it. The initiating causes may be helpful guides to FM subsets, offering direction for treatment options. FM itself affects the energy status of the body in so many ways that FM and TRPS may be the most common interactive conditions. Adaptations to sensory overload may themselves create a variety of biochemical neurotransmitters, hormones, etc., cascades that may initiate yet other cascades. These biochemical imbalances vary from patient to patient. As you will discover in the gallery, some TRPS can cause cognitive deficits as well. In FM, there may be a multitude of biochemical imbalances that must be gently brought back into harmony. The good news is that whatever helps FM will indirectly help TRPS, and whatever helps the TRPS will help FM. Someone can't have FM only in the hands or in the back. The CNS is the brain and spinal cord. It affects the whole body, causing a diffuse pain all over. FM does not cause localized pain. If there is localized pain, it's caused by something else, although FM may also be present. Often, but not always, localized pain is caused by one or more TRPS. Many symptoms usually blamed on FM are due to other causes, most commonly TRPS. We suspect that all chronic illness may have a myofascial component. For example, people with OA, Parkinson's disease, and other chronic illnesses have a TRP component to their symptoms. This is good news because the TRP component can be treated and the overall symptom burden can be lightened. Subscribe for more such content. All the best for your studies.